Hello everyone, this is Dr. Shiwani Chaturvedy, and in this video I will be discussing about corneal ulcers. So let's begin. Corneal ulcer is an epithelial defect associated with stromal infiltration, necrosis and tissue loss, and it can rapidly progress to stromal destruction, corneal perforation and irreversible visual loss, making early recognition and targeted treatment crucial. So, after that, we can classify it in 4 practical ways based on etiology, location, depth, and clinical course. First, by etiology, ulcers can be infectious or non-infectious. The non-infectious one include immune-mediated ulcers, and identifying the likely cause is important because the clinical appearance and treatment differ considerably. Second, by location, we describe the ulcer as central, paracentral, or peripheral. A central ulcer is particularly important because even a relatively small scar can significantly reduce the vision. And peripheral ulcers may have less direct effect on the visual axis but can be associated with immune-mediated disease or adjacent scleral inflammation. Third, we can classify ulcers according to depth. They may be superficial, mid-stromal, or deep. The deepest form may progress to descemetocele, requiring urgent management. Finally, according to the course, an ulcer may be acute, chronic, progressive, or recurrent. Before examining the eye, a focused history can provide important clues to the cause and severity of the ulcer. We should ask about the duration, progression of symptoms, pain, severity, and vision loss. Specific risk factors include vegetative trauma, which is commonly associated with fungal corneal ulcer, or contact lens use, previous herpes infection, recent ocular surgeries, or any topical steroid use. Also inquire about diabetes, rheumatoid arthritis, any immune suppression, or any previous treatment. The history helps us guide the differential diagnosis and determines the urgency of microbiological investigation and management. Now, the healthy ocular surface protects the cornea through 3 primary defenses: the corneal epithelium, conjunctiva, and tear film. Together, they provide anatomical, mechanical, cellular, and chemical protection. These defenses can be broadly classified as anatomical, mechanical, and antimicrobial barriers. Breakdown of any of these mechanisms, particularly an epithelial defect or inadequate tear film, can predispose the cornea to ulceration. And now, the anatomical barrier includes the orbital rim, eyelids, conjunctival epithelium, and intact corneal epithelium. The mechanical barrier consists mainly of the tear film, blinking, and recrimal drainage, which helps wash away organisms and debris. The antimicrobial barrier include conjunctiva-associated lymphoid tissue, tear film components such as IgA, complement, lactoferrin, lysozymes, and beta-lysins. Disruption of any of these barriers can increase the risk of corneal infection and ulceration. Now, this slide illustrates the classical 4 stages in evolution of a corneal ulcer, particularly in bacterial keratitis, starting with the stage A, which is a stage of progressive infiltration. After epithelial disruption, inflammatory cells, initially lymphocytes and other leukocytes, accumulate in the epithelium and adjacent stroma, and the tissue necrosis may begin at this stage. The next is the stage B, which is a stage of active ulceration. Necrosis involving the epithelium may extend through Bowman's membrane into the stroma. Clinically, this is associated with grayish infiltration, circumcorneal hyperemia, and sometimes anterior chamber reaction or hypopyon. The ulcer may continue to enlarge or deepen. Then stage C, which is a stage of regression, the host immunity and appropriate treatment begin to control the infection. A demarcation line develops, inflammatory cells phagocytose organisms and necrotic debris, and epithelial healing begins from the ulcer margins. The ulcer can appear to enlarge briefly as devitalized tissue is removed. Then finally, stage D, which is a stage of cicatrization, the epithelial defect becomes covered by new epithelium while stromal repair produces a residual corneal opacity or scar. The final visual outcome depends mainly on the ulcer's location, depth, degree of inflammation, and whether the visual axis is involved or not. Thus, the clinical priorities are to recognize the progression early, obtain appropriate microbiological samples, and initiate targeted treatment, and prevent the complications such as deep stromal melt or perforation. Is a key clinical feature of a corneal ulcer. The ulcer represents an epithelial defect with underlying stromal tissue loss. Around it, we may see grayish-white infiltration, and the surrounding cornea may develop corneal edema, producing stromal haze and decreased vision. Superficial vascularization indicates long-standing inflammatory process or healing response. It is not normally present in healthy cornea, and severe inflammation may extend into the anterior chamber and produces hypopyon, which is a layered collection of inflammatory cells. Therefore, while examining an ulcer, we must document the epithelial defect, infiltration, edema, vascularization, and antechamber reaction and hypopyon, along with the depth and size of the lesion. Now, Jones criteria help us grade a corneal ulcer as mild, moderate, severe using three main parameters: ulcer size, stromal depth, and scleral involvement. A mild ulcer is less than 2 millimeters in diameter and involves less than 20% of the corneal thickness and has no scleral involvement. A moderate ulcer measures 2 to 5 millimeters and involves approximately 20 to 50% of the corneal thickness and still has no scleral involvement. And a severe corneal ulcer is larger than 5 millimeters, extends beyond 50% of the corneal thickness, and involves the sclera. This grading is clinically useful because increasing size and depth indicate a higher risk of stromal melt, perforation, and visual axis involvement, and poor visual outcome. However, location, rate of progression, antechamber reaction, hypopyon, and impending perforation should also be considered while assessing the severity. Now, this slide compares the typical clinical patterns of 4 major types of infectious keratitis, starting from bacterial keratitis, which usually presents acutely with pain, rapid progression, mucopurulent discharge, stromal infiltrates, and often mobile hypopyon. Then fungal keratitis generally follows a more indolent course. Look for elevated, dry, rough infiltrates with feathery margins, satellite lesions, and relatively fixed, thick hypopyon. And viral keratitis, particularly herpes simplex, commonly cause pain, photophobia, watering, fine dendritic epithelial lesions, and most important, reduced corneal sensation. Then coming to acanthamoeba keratitis, it should be suspected when pain is very severe or disproportionate to the clinical signs, especially in contact lens wearers. And there will be ring infiltrates, pseudodendrites, radial keratoneuritis, and satellite lesions are important clues. These findings are suggestive rather than diagnostic because clinical appearance can overlap, so microbiological testing is very essential in atypical, severe, or non-responding ulcers. Now, this slide shows characteristic patterns associated with selected bacterial corneal ulcers. Staphylococcal ulcers are usually localized with distinct borders, relatively little surrounding stromal edema. Pneumococcal ulcers are usually present with dicryocystitis and can spread rapidly and cause severe antechamber reaction, melting, and perforation. Pseudomonas ulcer are highly aggressive with greenish-yellow discharge, rapid progression, stromal melting, and sometimes ring ulcer. Nocardial ulcers may have characteristic wreath-like pattern, and a microbacterial ulcer may show a cracked windshield appearance. Now, this shows a classical clinical appearance of a fungal keratitis. The ulcer has a dry gray-white infiltrate with raised feathery margins. Separate satellite lesions may be present around the primary infiltrate, reflecting extension through the corneal stroma. A fixed hypopyon may occur because of the intense antechamber inflammation. And these features, especially feathery margins, dry, raised borders, satellite lesions, and a relatively indolent course, should raise suspicion of fungal infection, particularly after vegetative trauma. However, clinical appearance is only suggestive. Confirmation requires corneal scraping for KOH, fungal stains, and culture. Now, coming to the diagnosis part, corneal scraping is most valuable specimen for diagnosing a suspected microbial ulcer. We can also examine conjunctival swabs, contact lens cases, and solutions, and when necessary, corneal or suture biopsies. So, direct microscopy provides an early diagnosis. We can do gram stain for bacteria, KOH, or KOH for fungi, and selected stains such as GIMSA, ZN stain for specific organisms. The specimen should also be cultured. Blood and chocolate agar support bacterial growths. Sabarod's dextrose agar is used for fungi, and additional media or broth may be selected when acanthamoeba, anaerobes, or unusual organisms are suspected. Culture and sensitivity helps confirm the organism and guide the targeted therapy. Now coming to the most important, corneal scraping. So corneal scraping is not required for every small peripheral ulcer. It is strongly indicated when the ulcer is central, larger than 2 millimeters, or associated with significant stromal involvement or melting. We should also scrape ulcers that do not respond to broad spectrum antibiotics. Ulcers after corneal surgery have atypical features suggesting acanthamoeba or microbial infections or show multiple infiltrates. Ideally, specimens should be collected before antimicrobial therapies is started. Although scraping is ideally performed before starting the therapy, this is not always possible because many patients present late or have already received the treatment. So in a non-responding ulcer, especially when the initial cultures are negative, we should reassess the diagnosis, adherence, drug toxicity, or possible atypical organisms. So repeat scraping or corneal biopsy may be required. So before repeat sampling, topical antimicrobials must be stopped for approximately 12 to 24 hours. And this should be done only under close ophthalmic supervision, particularly in severe or progressive ulcers. This slide highlights common errors during corneal scraping that can reduce the diagnostic yield or cause contamination. The procedure must be performed with proper gloves, aseptic techniques. Scraping should be controlled and preferably directed towards the active ulcer margins. And multidirectional or superficial scraping may produce inadequate sampling. Before sampling, gently clean the excessive discharge without contaminating the cornea. Avoid touching the lashes or eyelids and use a fresh, sterile instrument for each sample. Finally, specimens should be inoculated or sent promptly, and microbiology reports must be followed up in time so that treatment can be adjusted appropriately. Now, corneal scraping is generally safe, but complication can occur, particularly with deep and improperly performed scraping. The epithelial defect may temporarily enlarge, and disruption of surface can increase the risk of secondary infection. In a very thin or deep ulcerated cornea, excessive pressure may precipitate stromal perforation. Also, healing may result in corneal scarring, especially when the ulcer is central and already involves the deeper stroma. Therefore, scraping should be gentle, targeted, and performed with careful assessment of corneal thickness and structural integrity. Now, Gram stain is an early guide and helps in rapid classification of bacteria. Gram-positive organisms retain crystal violet and appears purple, often as cocci in clusters or chains. The upper image shows gram-positive cocci in grape-like clusters suggestive of staphylococci, and gram-negative organism loses the crystal violet stain during decolorization and appears pink after counter-staining. The lower image demonstrates gram-negative bacilli, which may be seen with organisms like Pseudomonas. So the final identification and antibiotic selection should be based on the culture and sensitivity results. It is just an early guide. Now this slide demonstrates two important gram stain patterns. The upper image shows gram-positive organisms arranged in chains, which suggest streptococci, and the lower image shows gram-negative cocci in pairs or diplococci, and gram-negative diplococci should raise suspicion of gonococcal infection. So gram staining provides a rapid presumptive diagnosis, but the organisms must be confirmed with culture and appropriate susceptibility testing. Now the KOH staining demonstrates the main fungal morphology seen in corneal scrapings. The left image shows round budding yeast cells suggestive of yeast-like fungi such as Candida. The middle image shows highly septate hyphae with acute angle branching and a regular pattern classically associated with Aspergillus, and the right image demonstrates long colorless filamentous hyphae compatible with Fusarium. However, KOH morphology is only suggestive. Fusarium and Aspergillus can overlap microscopically. So culture is needed for reliable identification. Now this table compares the diagnostic performance of gram stain and KOH stain. For bacterial keratitis, gram stain has moderate sensitivity but high specificity. So a positive result is useful, although a negative result does not exclude the infection. For fungal keratitis, KOH has highest sensitivity and very high specificity in this data set, making it particularly useful for rapid detection of fungal elements. So these values vary between studies and depends on ulcer size, specimen quality, prior treatment and lab technique. Therefore, stains provide rapid guidance, but culture remains the important for confirmation and treatment planning. Culture is performed by inoculating the corneal scraping directly onto appropriate media at room temperature. Blood agar supports routine aerobic bacteria, while chocolate agar is useful for more fastidious organisms such as Haemophilus or Neisseria. Seborrhoeic dextrose agar is used for fungi. Multiple gentle C-shaped streaks helps localize the inoculum and avoid puncturing the agar. The media should be closed and transported to lab immediately to reduce the contamination and preserve the organism's viability. Now this table summarizes the choice of culture media according to suspected organisms. Blood and chocolate agar are used for routine and fastidious bacteria. Thioglycolate broth helps recover aerobic and anaerobic organisms. LJ media are used when mycobacteria or nocardia are suspected, while Thiamartin agar supports Neisseria. So this slide compares blood agar with chocolate agar. These are the two most commonly used culture medias. So blood agar contains intact RBCs and it supports many bacteria and allow us to observe hemolysis like alpha, beta or gamma, which can help us in identification. While chocolate agar is prepared by heating the blood and lysis of the red cells. These releases essential growth factors, making it useful for fastidious organisms such as Haemophilus or Neisseria. Because the red blood cells are already lysed, hemolysis cannot be assessed on chocolate agar. So the key difference is therefore intact versus lysed RBCs. These photographs demonstrates the difference in growth on the two media. Neisseria gonorrhea grows better on enriched chocolate agar, which provides the nutrients released by lysed RBCs and is usually incubated in increased carbon dioxide. And in contrast, Staph aureus grows rapidly on blood agar, where colonies, morphology and hemolysis can be assessed. Thus, the choice of culture media depends on the suspected organism and its nutritional requirement. Finally, to corneal biopsy, which is reserved for difficult or refractory cases. It is considered when there is poor response to appropriate treatment, repeated negative cultures, or a deep mid-stromal infiltrate with relatively uninvolved superficial tissue. Unlike routine scraping, biopsy provides access to deeper corneal tissue for microbiological cultures and histopathological examination. It is particularly useful when atypical or slow-growing organisms are suspected, but it must be performed cautiously in a thin cornea because of the risk of perforation. Lastly, suture biopsy, which is useful when the infection is deep-seated, such as deep corneal abscess, and routine scraping is unlikely to reach the lesion. A short 7-0 or 8-0 vicryl or silk suture is passed through the depth of infiltrate, and the suture is then cut into two pieces and sent for bacterial and fungal cultures and sensitivity. This technique allows sampling of organisms from deeper stroma while avoiding excessive surface dissection. It should be performed carefully because a thin cornea can perforate. Early recognition, meticulous clinical examination, and appropriate microbiological workup are essential in corneal ulcer cases. And in the next video, I will discuss the treatment approach and the important complications of corneal ulcer. Thank you.